Take a normal breath in, through your nose. Let it out, not forcefully, just an ordinary exhale. Now close your mouth. Pinch your nose between your thumb and forefinger. And begin to count. 1, 2, 3. You are looking for the first definite urge to breathe, not the panic, not the gasp. The first real signal from inside that says, now. Do not stop counting if you are still going. Keep going while I tell you what is happening inside your chest and inside your skull and inside the wall of every artery in your body during this very small experiment. Most of you will arrive somewhere between 20 and 40 seconds. A few of you, the well-conditioned, will pass 60. Some of you will stop before 20. And that group is the one I am most concerned with tonight. Whatever number arrives for you, write it down. That number is going to predict something about your cardiovascular future that the most common test in modern medicine, the cholesterol panel, cannot. I want to spend the next half hour explaining exactly why. We tend to think of the breath as a thing the lungs do. That is wrong, actually. The lungs are passive participants. They are bags. They expand because something else pulls them open, and they collapse because that something else lets go. The work is done elsewhere, by a flat dome of muscle under your rib cage called the diaphragm, by small muscles between your ribs, and most importantly for tonight, by a cluster of nerve cells at the base of your brainstem that nobody talks about at dinner. Sit upright. Place 2 fingers on the soft spot at the back of your neck, where the skull meets the spine, your thumb on the front of your throat. Between those 2 points, inside you, is a structure called the medulla oblongata, about the size of an almond. It runs you in a way that you, the conscious person, will never experience directly. It runs your heartbeat. It runs your blood pressure. It runs the urge to breathe. You can override it for short stretches, that is what you are doing right now, if you are still holding, but you cannot override it for long. Within that almond-sized structure, 2 regions are doing the work I want to discuss. There is the ventral respiratory group, which generates the rhythm of breathing the way the sinoatrial node generates the rhythm of the heart. And there is a region near the underside of the medulla called the retrotrapezoid nucleus, which contains specialized cells that do something nobody told you about in school. They taste your blood for carbon dioxide, not oxygen, carbon dioxide. And running down from the brainstem, branching outward through the great wandering pathway that the old anatomists called the vagus, is a network of fibers that touch your heart, your lungs, your stomach, your gut, your spleen. Almost every visceral organ in the body is innervated by a single nerve descending from a single brainstem region. The breath hold is going to put that whole apparatus on display. Let me now tell you what each part is doing. The first event is chemoreception. Most people, if you ask them, will tell you the urge to breathe is the body's demand for oxygen. It is not. It is the body's demand to be rid of carbon dioxide. The urge you are feeling right now, if you are still holding, is not your cells crying for fuel. It is the chemoreceptors in your medulla detecting that the pH of the cerebrospinal fluid bathing them has dropped by a few hundredths of a unit, because dissolved carbon dioxide is being converted to carbonic acid, and the acid is making those cells fire. The number to remember is 40. The healthy chemoreceptor population in your medulla begins to alarm when the partial pressure of carbon dioxide in your arterial blood crosses approximately 45 millimeters of mercury, up from a resting value of 40. A 5-point rise. That is the trigger. Here is the part that matters for tonight. The set point of those chemoreceptors is not fixed. It is calibrated by your cardiovascular and metabolic life. Konstantin Buteyko, a Soviet physician who began this line of research in Akademgorodok near Novosibirsk in the 1950s, noticed something in his cardiac patients that the rest of cardiology was not noticing. The sicker the heart, the lower the carbon dioxide tolerance. The patients who panicked at the smallest air hunger were the same patients whose hearts were laboring. Buteyko proposed that chronic overbreathing, breathing too much, too often, without need, had recalibrated the chemoreceptors to fire at lower and lower thresholds, creating a feedback loop that worsened with worsening cardiovascular function. Massimo Piepoli and Andrew Coates, working at the National Heart and Lung Institute in London in the late 1990s, took this further. In patients with chronic heart failure, they measured peripheral chemoreceptor sensitivity directly and found that heightened sensitivity, the same hypersensitivity Buteyko had inferred, was an independent predictor of mortality. The chemoreceptors were not just downstream of failing hearts. They were active participants in the spiral of decline. Now, the breath hold tests this directly. A long breath hold requires low chemoreceptor sensitivity. A short, anxious breath hold reveals the opposite. But the chemoreceptors are only the obvious half of the story. While they are alarming, another nerve, far older in evolutionary terms than the chemoreceptors, is making a quieter and more consequential decision about your future. That nerve is the vagus, 10th cranial nerve. It runs from the brainstem down through your neck, splits, wraps around the heart, branches into the lungs, dives into the abdomen, and innervates almost every organ between your throat and your colon. The vagus is the great brake of the body. It is parasympathetic. When the vagus fires, the heart slows. The blood pressure drops. The pupils constrict. The gut moves. The system calms. When you hold your breath, the vagus is busy. The diaphragm has settled into stillness, and a particular pattern called respiratory sinus arrhythmia, the slight speeding of the heart on inhale and slowing on exhale, which normally couples the cardiac rhythm to the rhythm of breathing, drops out. Without the inhale-driven inhibition of vagal output, the vagus fires more steadily, and the heart slows. Your pulse right now is almost certainly lower than it was 20 seconds ago, even though you are doing nothing. This is part of the diving reflex, which we will come back to. But it is also a real-time measurement of how much vagal capacity you have available. People with high baseline vagal tone slow more and tolerate the slowing comfortably. People with low vagal tone barely slow at all, and what slowing they do is registered as alarm. Stephen Porges, who developed what he called polyvagal theory while at the University of Maryland in the early 1990s, made an argument that took decades to be absorbed by mainstream cardiology. Vagal tone, he proposed, measured as the high-frequency component of heart rate variability, is not merely a marker of relaxation. It is a global index of physiological resilience, the body's capacity to mount and to release an autonomic response without overshooting in either direction. He argued, and the subsequent 30 years of data have largely agreed, that vagal tone predicts mortality independent of cholesterol, independent of blood pressure, independent of smoking history, independent of diabetes, independent of age. A subsequent meta-analysis led by Andrew Kemp at the University of Sydney, drawing on tens of thousands of subjects across many cohorts, found that low vagal tone associates with greater all-cause mortality, with depression, with diabetes, and with cardiovascular events, and that the association persists after correction for every standard risk factor that cardiology measures. The vagus is not a downstream marker of cardiovascular health. It is a leading indicator, and the breath hold tests it. A long, comfortable breath hold requires high baseline vagal tone, low chemoreceptor sensitivity, and an autonomic nervous system that does not panic at small departures from homeostasis. A short, anxious one reveals the opposite. The number on your clock is, in a real and measurable sense, a snapshot of the parasympathetic capacity that has been quietly predicting your mortality for years. And while the vagus is slowing the heart, and the chemoreceptors are alarming the brain, an older reflex still, older than the vagus, older than the medulla, older than primates, is unfolding in your peripheral circulation. We share it with seals and whales and ducks, and it is happening to you right now. The mammalian diving response. It activates when three conditions co-occur. Apnea, you are not breathing. Facial cooling, cool air or water on the face. And slightly increased intrathoracic pressure, which the small tightness of holding a breath produces. When those three line up, your body executes a coordinated reflex that has been preserved across every air-breathing mammal that ever evolved. The reflex has three components, executed simultaneously. First, Bradycardia. Your heart rate drops, usually by 10 to 30% within seconds. Second, peripheral vasoconstriction. The small arteries in your fingers, your toes, your skin clamp down, shunting blood to the brain and the heart. Third, splenic contraction. Your spleen, which most people think of as a passive organ if they think of it at all, contracts and squeezes out a reservoir of red blood cells, increasing your hematocrit by up to 10% within minutes. Erika Chagatai at Mid-Sweden University has spent decades documenting this response. First in elite breath-hold divers, then in the bajau, the sea nomads of the waters between the Philippines and Indonesia, who hunt fish on a single breath at depths of up to 70 feet. Her measurements showed that splenic contraction alone could extend useful breath-hold time by approximately 20 seconds in trained individuals, and that the magnitude of the response correlated with cardiovascular reserve. The dive response is not optional. You have it. The question is how robustly it executes when triggered. Mike Tipton at the University of Portsmouth, working on the cold water version of the reflex, what happens when humans fall into cold water and either survive or do not, added a further layer. The diving response and the cold shock response compete. In well-conditioned individuals with intact autonomic function, the diving response wins, and the heart slows safely. In individuals with poor autonomic function, especially those with established cardiac disease, the cold shock response wins, and arrhythmias result. The same architecture that allows a healthy person to hold their breath for 60 seconds allows that same person on a different occasion to survive falling into a cold lake. Now consider the viewer over 50, the person who has been told by every modern wellness publication to do high-intensity intervals, lift heavy weights, track macros, the person who walks fast on a treadmill and considers themselves fit because the treadmill says so. That person may have a respectable VO2 max in the conventional sense and still have a damaged dive response, because the dive response is conditioned by exposure to apnea and to cold, neither of which a modern adult encounters routinely. The breath hold is one of the few ways such a person can still test the system at all. And while the heart is slowing, and the spleen is squeezing, and the peripheral vessels are tightening, the cells lining the inside of every artery in your body are doing something else entirely. This is the layer the cholesterol panel was supposed to predict. Your arteries are not pipes. That is the first thing to unlearn. Your arteries are organs. The inner lining of every artery in your body is a single layer of cells called the endothelium. And the endothelium is a chemical factory of formidable sophistication. When functioning correctly, it produces a small, short-lived molecule called nitric oxide, one nitrogen atom, one oxygen atom, a gas, that diffuses into the smooth muscle wall of the artery and tells it to relax. A relaxed artery is wider. A wider artery has lower resistance. Lower resistance means lower blood pressure and better tissue perfusion. Nitric oxide is the master regulator of vascular tone in the human body. It is also fragile, short-lived, measured in seconds, and produced poorly by endothelium that has been damaged by smoking, by high blood sugar, by chronic inflammation, by sedentary living, by, in some studies, even a single high-fat meal. During a breath hold, two things happen at the endothelial level. The mild hypoxia and hypercapnia stimulate nitric oxide synthesis directly. And the cyclic stretch of the artery, the heart is still beating, blood is still pulsing through, but now against a slightly altered chemical environment, provides a different mechanical signal that endothelial cells interpret as a call to produce more nitric oxide. Healthy endothelium responds. Damaged endothelium does not. David Sellermeyer, a cardiologist at the University of Sydney, is the figure most associated with the non-invasive measurement of endothelial function, a technique called flow-mediated dilation. His paper in the Lancet in 1992 established something that took years to be properly appreciated by the field. Endothelial dysfunction precedes the visible plaques of coronary artery disease by years, sometimes by decades. By the time your cholesterol panel looks alarming, your endothelium has often been failing quietly for a very long time. This is the heart of the problem with cholesterol as a primary screening tool. Cholesterol does not damage healthy endothelium directly. It damages endothelium that is already inflamed, already dysfunctional, already failing to produce sufficient nitric oxide. The cholesterol number is the smoke. The endothelial dysfunction is the fire. And the breath hold is testing the endothelium directly. A single integrated functional reading of whether the chemical factory in your arteries is still in business. A research team working in Central Europe, reviewed in the European Respiratory Journal, demonstrated measurable post-breath hold changes in flow-mediated dilation. Healthy subjects showed robust dilation. Patients with established cardiovascular disease showed blunted or absent responses. The breath hold was, again, doing what an expensive ultrasound machine does, in 30 seconds, with no equipment. And all of this, the chemoreception, the vagal slowdown, the diving reflex, the endothelial response, is being integrated by the organ at the center of the system. The organ the breath hold is ultimately measuring, the heart. We are now far enough into the breath hold that the right side of your heart is dealing with venous blood that carries more carbon dioxide than usual and slightly less oxygen. The left side, the side that pushes blood out to the body, is being asked to work in a slightly hostile chemical environment. A healthy heart, with sufficient reserve, manages this without complaint. A heart that has been quietly compensating for narrowed coronary arteries, for stiff ventricular walls, for valves that no longer close cleanly, begins to register the strain, and the brain receives that signal as anxiety, as the urge to breathe, as the desire to stop. This is why a research team led by David Anderson at Federation University, Australia, in a study published in 2012, found that simple breath hold time correlated significantly with measured VO2 max, the gold standard laboratory measure of cardiovascular fitness, and with cardiac autonomic balance. Subjects who held longer had more reserve, not because the breath hold trained the heart in the short term, because the breath hold was reading the heart that already existed. Igor Trembach and colleagues at Kuban State Medical University, studying patients before cardiac surgery, found that preoperative breath hold time predicted postoperative complications and mortality with surprising accuracy. Short breath holders, those finishing under 20 seconds, suffered significantly worse outcomes than longer breath holders matched for age and disease severity. The breath hold was not chosen because it was theoretically elegant. It was chosen because it worked. Now, before I go on, I owe you something. I owe you an honest accounting of what we know and what we do not. Because if I let this cascade continue without pausing, I would be doing exactly what I criticize other people for doing. Some of what I have told you tonight is on very firm ground. The relationship between vagal tone, heart rate variability, and cardiovascular mortality is among the most robust relationships in modern cardiology. It has been replicated across many laboratories, many populations, many decades. Hold that one with high confidence. The relationship between elevated chemoreceptor sensitivity and heart failure mortality is also well established. The Piepoli and Coates' work, and the work of subsequent groups, has been replicated. Hold that with high confidence. The mammalian diving response in humans, its components, its variability, its training, also well mapped. The Chagatai work on the Bajau, the Tipton work on cold water immersion, all of it consistent. The relationship between endothelial dysfunction and the eventual development of coronary disease is high confidence as well. The Cellar-Major work, the follow-up trials, the convergent evidence from a dozen different non-invasive measurement techniques. This is established cardiology now. The use of a simple, no-equipment, 60-second breath hold test as a standalone cardiovascular screening tool, that sits on weaker ground. The correlational studies exist. The Anderson work is real. The Trembach work is real. But they are smaller studies than the ones that establish cholesterol's role, and the breath hold has not yet been the subject of a large, blinded, prospective trial against modern cardiovascular endpoints in a general population. So when I tell you that the number on your clock predicts something real about your heart, Hold that claim with calibrated confidence. It integrates several well-validated markers into one cheap reading. It does not replace a cardiologist. It is a signal, not a verdict. And here is the part that does not appear in textbooks. The breath hold test is essentially unmonetizable. There is nothing to sell. There is no machine. There is no consumable. There is no insurance code. A research group that wants to study it must find independent funding, because no pharmaceutical company and no device manufacturer has a commercial reason to publicize a test that costs nothing and requires nothing. This is not a conspiracy. It is just the way the incentives work. And it is one of the reasons that, despite the physiological plausibility, the breath hold test has remained on the margins of cardiovascular medicine, while a $400 coronary calcium scan has not. Now let me make the comparison the title of tonight's lecture promised. Consider what your cardiologist's office offers in place of this 30-second test. A standard lipid panel costs your insurer between $40 and $100. An advanced lipid panel, including apolipoprotein B and lipoprotein a, costs $300 to $500. A coronary calcium scan costs $300 to $400. A stress echocardiogram costs $1,000 to $2,000. A coronary angiogram costs $5,000 and up, with a small but real risk of complication. Every one of these tests measures something real. I am not telling you to skip them, but notice what they measure. They measure structures that have already failed. Narrowed arteries, calcified plaques, lipoprotein particles concentrated to levels that would not exist in a healthy endothelial environment. They are detecting damage. They are the smoke alarm that goes off after the fire has already started. The breath hold measures something different. It measures function, autonomic function, endothelial function, cardiac reserve. It is detecting whether the systems that are supposed to prevent the fire are still working, whether the pilot light has gone out before the kitchen is in flames. And the same vagal tone the test reads, the same parasympathetic reserve that determines whether you can hold for 60 seconds or panic at 20, is precisely what cardiologists try to restore pharmaceutically when they prescribe beta blockers, when they prescribe ivabradine, when they prescribe certain classes of medication for hypertension. Beta blockers slow the heart by blocking sympathetic drive, which is functionally similar to raising vagal tone, although the molecular mechanism is the opposite face of the same coin. Ivabradine slows the heart by acting directly on the funny channel of the sinoatrial node. Both prescriptions target the same end state, a slower, more efficient heart with greater parasympathetic dominance. That long, comfortable breath holds reflect, and that breath training over weeks and months produces. There is, in fact, a medical device cleared by the United States Food and Drug Administration in 2002 specifically for the reduction of blood pressure through guided breathing. It is called Respirate. It retails for around $300. The underlying mechanism is identical to what daily breath hold practice produces over time. The chemoreceptors recalibrate. Vagal tone increases. The endothelium recovers function. Resting blood pressure falls. The device is a $300 package around a behavior your grandmother taught you for free. I want to be careful here. I am not telling you that a breath hold replaces a beta blocker. If you have established coronary disease and your cardiologist has prescribed one, you take it. The pharmaceutical doses the system with a precision and a magnitude that breathing cannot match in the short term. What I am telling you is that the body's version and the pharmaceutical version act on the same nerves, through the same molecules, on the same organs. The difference is dose, time course, and cost. One costs $300 and works in hours. The other costs nothing and works over months. They are not enemies. They are versions of the same intervention, separated by orders of magnitude in intensity and in price. And here is what makes the comparison sharper still. A statin lowers your cholesterol number. It does that reliably. But the chain from lower cholesterol number to fewer heart attacks runs through the endothelium, through the same nitric oxide pathway your breath hold tests. Statins, in addition to their cholesterol-lowering effect, are also weak nitric oxide stimulators in the endothelium, which is now thought by many researchers to be a substantial portion of their actual cardiovascular benefit. The molecular pathway that the breath hold tests cheaply and that breath training improves slowly is the same pathway that the most prescribed cardiovascular drug class on earth is, in part, trying to access. There was a phrase my grandmother used to use when I came running into the house breathless from playing, talking too fast about whatever had just happened outside. Take a deep breath. Calm down. Count to 10. I used to think this was a placeholder, the kind of thing adults say to children to buy themselves a few seconds before they have to actually engage. I have come to think it was the most sophisticated piece of medical advice anyone in my life ever gave me. Take a deep breath, slow the respiratory rate, drop the chemoreceptor drive, lower the carbon dioxide threshold over time. Calm down, engage the vagus, slow the heart. Count to 10. Establish a rhythm that the parasympathetic system can entrain to. She did not know about the medulla. She did not know about the vagus. She did not know about respiratory sinus arrhythmia, or chemoreceptor recalibration, or the endothelial release of nitric oxide. She knew that her father had lived to 93, and his father before him to 91. She knew that the long-lived men in her family had a particular quietness about them, a slowness of breath, a steadiness of pulse, an apparent imperturbability that her own anxious generation had begun to lose. In 3 sentences, she was passing down a piece of cardiovascular medicine that the field is only now formalizing. The breath hold is not a new invention. It is the test that reveals whether you have inherited, or whether you have cultivated, the quality the older generation called composure. The field is now calling it parasympathetic reserve. They are the same thing. So, here is what I want you to do before you go to sleep tonight. Sit upright. Empty your lungs gently. Pinch your nose and begin counting. Whatever number arrives, 20, 40, 60, that is your starting line. Write it down. Do it again tomorrow. Do it again next week. With consistent practice, slowly and without forcing anything, the number rises. Each rise is a real change in the calibration of the systems we have walked through tonight. The chemoreceptors quiet. The vagus strengthens. The endothelium recovers. The number on the clock is